All right, let's dive into something that is, well, incredibly tough: medical ethics. We're not talking about abstract puzzles here. These are real, life or death decisions that doctors and nurses have to make, sometimes in a split second. So, how on earth do you make the right call when there's no easy answer?
I mean, just think about this for a second. Put yourself in the doctor's shoes. You have two patients who will die without a ventilator, but you only have one machine. One patient is so sick their chance of survival is almost zero, even with the ventilator. The other is less severe, but they still need that machine to live, and with it, their chance of survival is actually pretty high. Who gets it? Yeah, this is the kind of impossible choice that medical ethics is all about. So, to navigate these incredibly murky waters, you need a map, a clear one. For this explainer, we're actually working from a really fascinating analysis of these classic dilemmas that was compiled by ChatGPT. It gives us a logical framework to break down these huge, complicated problems into steps we can actually understand.
And here's our game plan. First, we're going to build our thinking toolkit, the core principles you absolutely need to know. Then, we'll see how they work in some classic scenarios. After that, we dive into the really tough gray areas, like DNRs and resource shortages. We'll also cover the top 10 ethical traps people fall into. And then we'll wrap it all up by giving you a universal framework for thinking through these decisions.
Okay, first things first. Let's get our toolkit ready. Pretty much every ethical dilemma in medicine you'll see can be understood by balancing 4 fundamental principles. Once you get these, you can start to take any problem apart. So here they are, the big 4. Autonomy, that's simply the patient's right to choose for themselves. Beneficence is the duty to do good for the patient. Non-maleficence is probably the most famous one. First, do no harm. And finally, justice, which is all about fairness and how we distribute care. You see, almost every single dilemma is just a conflict between 2 or more of these. But, and this is so important, there is a hierarchy. And the number one most crucial rule is this. For any patient who can make their own decisions, autonomy is king. Their informed choice trumps almost everything else. You gotta remember that. It's the key to solving like half the problems we're about to talk about. Okay, we've got our principles. Now, let's see how they actually work. We're gonna put them to the test with some classic real-world scenarios. All right, case number 1. So you have a patient, they are completely lucid, they understand their cancer diagnosis, they understand what's likely to happen, and you've told them that chemo gives them the best shot at survival. And they just look at you very calmly and say, "No, thank you." What do you do now?
Well, this is a perfect illustration of a direct conflict, right? The principle of beneficence, your duty to do good, is screaming at you to give the treatment. But the principle of autonomy, the patient's right to choose, is pulling you in the complete opposite direction. So, which one wins the tug of war?
And the answer is crystal clear: autonomy. As long as that patient has the mental capacity to understand and decide, they have the absolute right to refuse treatment. Even if that decision seems wrong to us, even if it will lead to their death, it has to be their choice, period.
Okay, let's try another one that happens all the time. The family pulls you into the hallway and begs you, "Please, doctor, don't tell our mom she has cancer. The shock, it'll be too much for her." You know they're coming from a place of love, they think they're protecting her, so what's your ethical duty here?
And once again, autonomy is our guide. The patient, and only the patient, has the right to their own medical information. The family, no matter how good their intentions are, can't take that right away from a capable adult. The primary relationship here is between the doctor and the patient, not the doctor and the family. So those first couple of cases were, well, relatively straightforward. But now we're heading into the gray zone. This is where the principles start to clash in much more complex and honestly heartbreaking ways. This is where it gets really, really tough. So, what about a situation like this? A patient signed a do not resuscitate order a year ago, probably thinking about a totally different illness. But today they have a sudden cardiac arrest from a brand new problem, one that's highly treatable. If you resuscitate them, they could live for another 10, maybe even 20 years. That old piece of paper says don't intervene. What do? This is where you have to be more of a detective than a doctor. You can't just blindly follow the paper. First, you have to ask, is the DNR even valid for this specific situation? Was it signed when they were thinking about end-stage cancer, not a fixable heart problem? Second, you talk to the family. Did the patient ever change their mind? What were their values lately? And finally, you have to decide based on their presumed will. The real question isn't, what does the paper say? It's, knowing everything we know now, what would this person want us to do for them today? And this gets to a really critical idea. A DNR isn't some magical, unbreakable command. Think of it as a powerful piece of evidence about what a person wanted at a specific point in time. But when the entire context changes so dramatically, our duty is to honor the person, not just the paper. Now, let's circle all the way back to that ventilator problem from the very beginning. Remember, patient A is critically ill, basically no chance of survival even with the machine. Patient B is not quite as sick, but will definitely die without the ventilator and has a really high chance of survival with it. The difference in who could benefit is just massive.
And here's the tough, correct answer. The principle of justice in this case isn't about first come, first served. It's not even about who's the sickest. It's about maximizing the good you can do with what you have. It's a utilitarian calculation. You have to give the scarce resource to the person who will benefit the most from it to maximize the number of lives saved. So patient B gets the ventilator. It's the harsh but ethical reality of triage. You know, knowing the principles is one thing, but avoiding the traps our own intuition sets for us, that's a whole other challenge. So let's run through the most common mistakes people make when they think about these problems. And the number one biggest trap is the one we just talked about. Our gut, our instinct, tells us to run to the person who looks the worst. But ethics, especially in a crisis with limited resources, demands that we help the person we can actually save.
And here are a bunch of others. Putting the family's wishes before the patient's. Confusing a decision you disagree with, calling it irrational, with the patient actually being incapable of deciding. Treating a DNR like an absolute command, which we know ignores context. Thinking minors have zero say. They often do. Believing that if a medical error caused no harm, you don't have to disclose it, you absolutely do. Using benevolent little white lies. Assuming a first-come, first-served rule for resources. And finally, the belief that a doctor has to always try to save a life, even when the treatment is completely futile. Every single one is a pitfall where our gut feelings can lead us astray.
Whew. Okay, we've gone through the principles, the scenarios, the traps. Now let's pull it all together into a simple, practical framework you can use to think through any ethical problem that comes your way. Really, it's a four-step process. Step one, and it's the most important question of all, can the patient decide for themselves? If the answer is yes, their autonomy rules. End of story. 2, if they can't decide, is there an advance directive, like a DNR or a living will? That's your next best guide. 3, how do you handle conflicts? Remember the hierarchy. The patient's own wishes, known or written, always come before what the family wants. And 4, if you're still stuck, you go back to your toolkit, autonomy, beneficence, non-maleficence, and justice, and you work through the conflict always remembering that autonomy comes first. So there it is, a framework for thinking through some of the hardest decisions a human being can ever make. You have the tools, you know the principles, you can spot the common traps. But the final question, that's always the hardest one. Knowing everything we've just talked about, if you were the one in that room, could you make the call?